Okay, this is the last discussion before we head to the BioSkills lab. So we'll talk a little bit about the different surgical techniques and barriers to coding, credentialing, and reimbursement. This is kind of an all-comers talk about describing the various challenges that we face when taking aboard new technologies, new procedures, including credentialing and battles and barriers that come out of just getting credentialing. I want to have a little bit of discussion about malpractice coverage, and for the new procedures you're doing, do you need an insurance rider, do you not? Things are important there. I'll talk to you about the mechanics of going from a Category 3 or a T code to a Category 1 code, and then CPT coding and how this evolves over time. There are commonly listed about 7 specialties that can do or occupy under the pie of the interventional pain physician. Here I've got 9 listed. And they're very heterogeneous, comes from all walks of life, all types of training. And so how do you credential people to do what is termed maybe interventional pain procedures? So, there was a time where I couldn't be trained or wouldn't be credentialed to do epidural injections of the lumbar spine in a big box hospital. Neither could my colleague, my partner, practice partner. So I asked the chairman of the credentialing committee, and this has been quite some time ago, said, so he could put a catheter in somebody's brain, take out the clot and save their life from a stroke, but you won't let him do a lumbar epidural injection? Yes, that's right. And so sometimes the credentialing committee becomes nothing more than just a battleground for turf wars. And so this is why the collaboration and cooperation is very good, because it wasn't until we shut down services to our colleagues that were trying to keep us out, for example, draining abscesses and embolizing bleeders, would they agree to say, okay, you guys can do something as innocuous as epidural injections. And so there's a dramatic heterogeneity, and because of the heterogeneity, I mean, how do you say somebody's credentialed should be capable of being credentialed to do a certain procedure? For example, so the family practice physician that's done 50 SI fusions in his fellowship training program be allowed to do SI fusions once they got out. And that commonly will be a scenario that maybe some people in the hospital will say, no, it's not appropriate training, whenever he's done more than every single other physician in that hospital combined ×2. So this is something that we have to keep in mind. It can be ground zero for turf wars, definitely. And what I would encourage you is to facilitate with documentation. And I send my fellows, offer them the capability of going to any of the training courses sponsored by industry, going to this training course, going to the fellows training course that is also here at the Saddle Science Foundation. And I'd say, encourage you, go to the course. The comment is, well, why do I need to? Why do I need to go to the Medtronic's kyphoplasty course when I'm going to do 650 vertebral augmentation procedures this year? The answer is for the piece of paper. Get the certificate, because this is something you can offer up. And for those of you, I would encourage you to tell the trainees to keep track of their procedure numbers. This, next to oxygen, is critically important to getting credentialed at places, especially if you come from a heterogeneous background. I'm an interventional radiologist, and I work in the world of interventional pain and spine surgery. So I've been around pegging a square hole my entire career, and really papering up your CV and yourself, your documentations of the procedures. That's how you're going to overcome a lot of this. So malpractice. So a lot of times we refer to these as insurance endorsements or riders. For example, do anybody know what this device is? Yeah, G3 Minuteman. This is an interspinous fusion spacer. How many people have done these? So, good handful. So, do you know if your malpractice insurance covers this or not? If you're an interventional pain physician, are you covered to do this, a fusion spacer, fusion of the lumbar spine? Makes you think, right? The answer is, I don't know. Depends on your insurance. Some insurance, particular brands will cover this without any additional insurance coverage known as a rider or an endorsement. So you can get the different, I have my basic insurance, and I have about 8 riders on there to cover things that are outside the bounds of what the typical insurance will cover. And so just make sure before you start doing some of these things that you're actually covered for this. In terms of category codes, we've discussed a Category 3, Category 1. We've discussed a T code. A T code, the transitional code, is the same thing as a Category 3. These are synonyms. Category 3 equals T code. What's the difference between a T code and a Code 1, Category 1 code? This is the difference. So a T code is a temporary code applied to a procedure, usually for about 2 to 5 years, in order to get utilization, in order to apply for the Category 1 code. And the Category 1 code will be applied with 5 pieces of literature, with the top level evidence level 2B. This will transition from a Category 3 or a new procedure to a Category 1 code that's associated with a certain CPT. The Category 3 code is one code. It has no RVUs, it has no global period, and it has no physician fee. So be aware of that. So what's a common Category 3 code that we have now? Well, BV&A went from a Category 3 to 64622829. So 0627T is the VIDIS code, and that's going to morph from a Category 3 to a Category 1. So no RVUs, no physician fee. So make sure and do it in a facility where you're not doing it for free, preferably in the office. But this BVN got additional 6462829, as I mentioned. Also, it got a separate ICD-10 code. And this is interesting. So vertebrogenic discogenic back pain is the most common cause of back pain. And on discussions with the chairman of the committee for ICD-10, we were talking about the lack of appropriate codes. And so we were talking about diagnosis for back pain. And I said, so let me see if I have this straight. There is no ICD-10 code for the most common cause of back pain. Is that correct? 3-beat silence? Yeah, I guess so. So that gave rise to this, and we'll probably have one for discogenic pain as well as vertebrogenic pain moving forward. This is it. This is the chart. This is what's necessary for Category 1 coding. As I mentioned, 5 pieces of literature. I said 2B. It's 2A, and this is a mixture of different authors and different data sets. So at minimum, you have to have 2 different data sets and no overlapping authors, a minimum coding of 2A. This is for a new one. So the maximum of 2B is for existing codes. So this should be a 2B right here, because we went through this just recently with SI Fusion. So the 2B was the secure trial, and this was the one that qualified again for a Category 1 code. So this is how it's determined. I mentioned a T code or a Category 3 has no RVUs, it has no global period, and it has no physician payment, no separation between technical and pro fee, just one global payment. So this, measure the work RVUs, the amount of work that it takes to do, the expenses that go into it, and then the malpractice RVUs, and this will create a total relative value unit. This is how a Category 1 code is made. And so you multiply this times the conversion factor that's been in the news this past year, and that will give you a payment rate. So before they do this, this is the process of determining the payment, and the work value and everything else goes through a process called crosswalking. So this will crosswalk. So you put a Category 3 code. How do you determine the value of the Category 3 code? You crosswalk it to something that's close. So disc augmentation with VIDIS. It was crosswalked to vertebral augmentation. So one, you augment the disc, the other, you augment the bone. And this is kind of how these payments are made. This is how they're determined. There's the T code 062728, and for CT, it's the latter. And these are the T codes that are in the process of becoming a Category 1 code. The data is collected, it's being submitted, and everything is in process. And this is how it goes. It's assigned an ambulatory payment classification. This particular one is APC 5115. Here are the codes up here, and here are the reimbursements attached to these codes. There's only 6 APC codes. VIDIS is a level 5, the same as a knee arthroplasty. And this will have, once it's assigned a Category 1, it will have physician fee, hospital fee, and associated ambulatory payment classification. And so the global period is after you do a certain procedure, you cannot do another procedure. This is determined, this is variable as determined by each Medicare administrative contractor. And insurance coverage, as we've seen, some of the MACs cover this, some will not. Some of the private commercial payers will cover it, some will not. And then the diagnosis codes for back pain are here. We developed a new one for vertebrogenic back pain just recently. Prior auths does not change whether you use a Category 1 or Category 3. And remember, approval doesn't necessarily mean a payment in the private carriers. So here's an example of how your procedure needs to determine the coding and vice versa. You need to mine the code. So if you're going to be using, to use a Minuteman as an example, 22612, 22840, you need to, this is an arthrodesis, right? So you're going to have to do a decompression here and visualization here. And these are the codes. Here's what is assigned to. And to be able to mine these codes, this is what you need to do. So directly visualize for a 22612 and including a decompression for a 22840. So this is what is necessary, your procedure needs to encompass in order to meet that code. And so if you're not doing this, you should be doing it. If this is beyond the bounds of the technology, industry often will provide tools to do this in order for you to be able to meet the code. A lot of these, when transitioning from more invasive to less invasive, if this were more invasive, this would be 4 screws and 2 rods, possibly an anterior interbody fusion, instead of this, for at least at minimum a posterior fusion, 4 screws and 2 rods. Some of these details are left over from the codes that have been traditionally an open fusion code, but this needs to be minded moving forward. For those of you who are not coding your major comorbidities, this will change your mind. So this is with and without major comorbidities for procedures like surgical fusions, SI fusion, kyphoplasty. The DRG that the hospital will assign to this is determined, is gained by determining the comorbidities. You have to document these comorbidities, and there's a very big difference. This is an article Pierce Nunley wrote a few years back that says the difference in payment makes more of a difference to document the comorbidities than it does whether you're doing the difference between a 1 and 2 level fusion. So it's more important to document the comorbidities than it is, the payment is more than doing additional levels of fusion. That's how important it is. And so this can represent tremendous amounts of loss, especially if you're not documenting the comorbidities for kyphoplasties in any type of fusion procedure. You're leaving lots of money on the table for this. This is what keeps the doors open and the lights on, makes the practice sustainable. So to be specific, some of the fusion codes are 22840, 22612 plus the allograft code. The autograft is different, and the hardware is an unlisted code. Medicare will not pay for the hardware, but it should be documented as this is billed to commercial payers. These codes, the 22869 and 70, all the way from 67 to 70, this is a non-fusion spacer. This is the Vertiflex Superion, is the only one approved here. There's a dozen in Europe. And then just make sure and apply the appropriate code and include the hardware in the documentation for private cases. For those of you guys doing spine endoscopy, 62380, this is the code now. It's been really replaced, this code, 62287, that's only used in some work comp areas, and it's used along with the 22526. This is a annuloplasty code. But this is the code, and this is released. This code, the 62380 replaced the T code, replaced that T code in 2017. So for those of you doing spine endoscopy, just remember that. And then we've talked a lot about this. 27279 is the minimally invasive SI fusion code. The 27280 is the open equivalent. And the new code, which is the CPT for the posterior fusion, 0334T, this replaced 27279 went from that to this in 2015. The 0775T will come a new posterior CPT this year, coming out in January, or really next year, January of 2024. This will become a new Category 1 code, so we'll have whatever that turns into, the 79 and 80 codes, all three of those. So just kind of a word on SI Fusion. This has kind of modified itself over time. Just in 2015 was the 27279 given a Category 1 code, which is, it seems like yesterday, right? But yet again, it seems like a long time, a lot of SI Fusion procedures. But the minimally invasive approach had better operative parameters, shorter op time, better outcomes in terms of pain, function, quality of life, was all the way around better. And it still took until 2015 to get a CPT code, a Category 1. So these are the recommended approaches. If you're going to do SI Fusion, we mentioned have 3 out of 6 physical examination tests positive for SI dysfunction pain, have an injection that's 75% or more in terms of reduction, and the diagnostic imaging are for purposes of exclusion, not necessarily inclusion. Trauma, tumor such as a chordoma, and seronegative and positive spinal arthropathy with SI joint erosions. So kind of pull it all together. The credentialing is difficult, can be a source of turf warfare. All of us are from different specialties. I look out and I see at least 4 different specialties that I can recognize. And everybody has different experiences. Paper it up, get certified, get some type of objective approval, including letters and courses and everything else. This will help your credentialing, especially if you're going into an area that's uncertain. Make sure with all the new procedures you do or are about to do that your malpractice insurance will cover you. If it doesn't, get a rider / endorsement. These are saying they're just termed different things by different insurance companies. By understanding a Category 3 to Category 1, you'll also understand that you're not going to be getting a physician fee for a Category 3 code. We also don't like to make mention of time. We don't brag about how quickly we can do stuff. I mean, I was on a conference call, somebody said, I can do a kyphoplasty in 7 minutes. And I unmuted and I said, well, you're doing it wrong. It sounded overtly harsh, and I didn't mean it to, but Neil and I have had this situation where we sit across from the Medicare carrier director for the MAC, and they're repeating back to us words that we've heard people say, how fast they can do it. Well, why are we paying a APC level 4 code, and why are we paying, let's see, this, if this can be done in 7 minutes? You know, you hear that back. So resist the urge to brag about how fast you are about doing procedures, because we do hear it back on the back end from the MAC medical directors, and this is not, you know, it's not reality. It's bravado more than that. And then understanding kind of how this coding is done will help you facilitate knowing where to do it and kind of how to approach it. CPT codes, it has a procedure description. Kind of know what these are, make sure you're adhering to common practice, make sure you're not doing anything outside the boundaries of that code. And documenting comorbidities, if you're not doing that now, it's an absolute essential portion for the hospital to recoup the adequate DRG payment. And you saw with and without major comorbidities in spine fusion. Without major comorbidity was about $20,000. With major comorbidity was up to $48,000. These are big numbers. So make sure and document the comorbidities. And then realize there's a new SI Fusion code coming out, and this is, that we'll see kind of how this transpires. There will be codes for everything, and the code for hybrid codes are 2 Category 1s plus a 51 modifier. And then this will continue, and this problem / process that I just described will continue to accelerate as we go from maximally invasive to MIS surgery to poke hole surgery. we're going to be minifying everything that we do. And with the minification of this, we also have better operative parameters, but we also have challenges because the coding system and the billing system is designed, the reporting system is designed to report on things in a traditional way that's typically more invasive. So these barriers will continue to present themselves, and just understand how it works. This is not the most exciting thing in the world. It doesn't have anything to do often with clinical data, but if you just understand the process, just this slide set, you'll understand what it takes to establish and maintain and receive a CPT code, an ICD-10 code, and the Category 3 to Category 1 coding process. And once you understand the basics, then the dollars and cents follow it, and the ability to develop new codes becomes not a challenge. It becomes less ethereal and nebulous and more really rote. That table chart that I put up there for the Category 1 requirements, just knowing that, you can advise companies about how to do this. I'm surprised about how many companies come through this and try to get a Category 1 and don't really have a good idea about what the requirements are. So just know this, and it will be to your great advantage over the course of your career. With that, I'm going to stop right there. Questions, comments? Snide remarks. Neil.
So, Doug, what impact has correct CPT, ICD-10, correct coding had on your practice? And for those going into practice, what advice can you give them?
So this is one of those things that, frankly, I don't like doing too much, is reading the codes and making sure we're adhering to this. Having my documentation be fastidious enough to reflect exactly what we're doing. But you have to. And every so often, I've got about 300 template reports. I go back and I refine these. As soon as the requirements change, I go back and make sure they're updated and modified. You know, the income in your practice next to oxygen is the most important thing that you have. That is your life sustainability to keep your doors open and your lights on. When I saw Pierce's paper about the comorbidities, I thought, I know that. And when we brought it to one of the hospitals, you could hear a pin drop in that conference room. They suddenly realized, like, oh my God, for decades, this has not been going on. And this, you know, this is something that just, you have to mind every element in your practice. And these are, I've been impressed by something, and this will sound odd, but I like the CPT coding system. I like the ICD-10 system. I mean, as Byzantine as it seems, it's actually pretty straightforward. I mean, it codes like kind of it should. The numbers make sense. And all it takes is just like anything else, like learning to count or learning another language, all it takes is just to familiarize yourself with it once. And, you know, that's a learned skill. Put it in your pocket, carry it with you. You'll always have that capability, and you won't forget it. It will take care of you just to learn this and to mind the financial health of your practice. It's incredibly important. Questions, comments? Ramo.
I was trying to think of a snide comment, but I couldn't come up with one. I think everyone should know how much work is being done on coding. So I worked for the World Health Organization for a year and a half and was next to the office that did the International Classification of Disease. And when I got into this world, I thought there's no way we can change the ICD-10 or ICD-11, and yet we've done that. I mean, we've seen in the last few years a change in M48.06 to with or without neurogenic claudication. And what I started to realize, a lot of our disease states that we classify are based on radiology. So M46.1, that's sacroiliitis, seeing inflammation around the joint. But is that really describing a patient who has pain from the sacroiliac joint? Or what Doug brought up, discogenic pain. We've talked about discogenic pain for decades. That's not even a diagnosis. Facetogenic pain, what do we use? We use these other codes to describe facetogenic pain. What about coccyx pain? It's the same as sacrococcygeal, M53.3. So I think all of us in this room, it just can't be me or Doug or Neil or John. we need to do a better job in helping our friends understand these codes so that we as pain physicians or surgeons or whoever, every doctor who deals with pain can help our patients. I think we're really, really Byzantine as far as where we should be with coding.
Couldn't agree more. Definitely room for improvement. All right, you guys, shall we transition over to the lab?